Good morning, everybody. I'm Mary O'Keefe. Welcome to this Q&A session on end-of-life care. We're delighted to be joined by two of the speakers from the EFIC Academy, so Professor Sam Amazad and Manohar Sharma. And we hope you've got the opportunity to watch their lectures already on the Academy. So please ask as many questions of Sam and Manohar as you can. They're going to start off by introducing themselves and then we'll get into the questions. Okay, Sam, would you like to open the floor first with an introduction?
Thank you very much, Mary. Good morning, everybody. So I'm Sam Amazad. I live in England. I am a retired emeritus professor of palliative medicine at the University of Sheffield. For many years, I was working in pain management and symptom management in cancer patients, but also in non-cancer patients as well. And my involvement in the pain world is that I was a council member of the British Pain Society. I chaired the education committee, and so I'm a strong supporter of pain organizations such as EFIC.
Great, thanks, Sam. And Manohar, would you like to introduce yourself?
Thank you. Good morning to you all. I'm Manohar Sharma, and I'm consultant in pain medicine with anesthetic background. And I'm based in Liverpool at the Neurosciences Center. And I'm also actively involved in clinical practice in cancer pain, but also other chronic pain management, including neuromodulation and general sort of pain management for, like, facial pain and pelvic pain. And also I got involvement with Faculty of Pain Medicine, being a board member and also a previous examiner for award of FFPM-RCA, like pain exam, pain degree, in UK. And also I got a very good working relation with palliative medicine in Liverpool, as well as with neurosurgery. So I think that is the key to sort of, bring together a plan for a patient with cancer pain as to how you could help them. So that's my background, which I bring to this session. Thank you.
Great, thanks, Manohar. So just before we start, Sam, did you have slides you wanted to share?
Yes, please, Mary. I'm just going to share a selection of some of the slides which some of you will have seen in the webinar, just to set the scene and to explain where I'm coming from, and also some of the key points I think that could be part of this discussion. So if I can share the screen, which one here? Now, can I just check? Are you able to see that slide?
Perfect. Yep.
Okay, so if I put the slide on. So this was my introduction. So as I said, I'm a physician. I worked in the University of Sheffield, but I'm now retired from clinical practice. I still do a lot of my academic work. So my talk originally was about managing non-pain symptoms. And it did seem a bit strange to do that for a pain webinar with EFIC. But the reason I covered that, I was asked to cover that, is because particularly in cancer and in modern pain management, we are using a biopsychosocial model. So we can't look only at the pain. We have to have a holistic view of what's going on in the life of the patient and also the family carers as well. And of course, we understand that in cancer, just like in other chronic inflammatory conditions, pain is important, but sometimes it's not the most important thing for the patient. So as a pain specialist, we should be having a broader view. And that's the other thing, which I'm hoping will come up in this meeting, is that we must realize that some of the symptoms that cancer patients experience as they go through their illness, and particularly in the end of life, are actually not coming from the cancer. They're coming from the drugs we use for lots of reasons, including pain management. So that's why pain specialists should really be aware of the broader picture. The drugs that we particularly focus on, but I hope we talk about others, are the opioids. Opioids are clearly very important in pain management, and particularly in advanced disease, because pain reaches very high levels. But we must recognize that opioids cause very, very numerous and very severe important side effects. The easy ones we all know about: constipation, dry mouth, nausea and vomiting, drowsiness. We see that in almost every patient initially. Some of them get better. Constipation does not get better, so you have to always look out for it. But cognitive impairment, hallucinations, some patients have terrible itching with opioids or have urinary bladder retention. And of course, we teach all our medical students to look for respiratory depression, but sometimes we're over concerned and we hold back on opioids just for the fear of respiratory depression. We always have to be very careful with our dosing. Nowadays, we must be very aware when using opioids, particularly because patients are using them sometimes for longer term. Our cancer survivors are using them sometimes for many months. Endocrine suppression, lower testosterone, ACTH, immunosuppression. There's growing evidence about that. We don't know the impact that has on patients' lives. And a very important one, which I hope will come up in the discussion, is opioid-induced hyperalgesia, where the opioids are actually contributing to the patient's pain. I like to use this slide in my teaching. The patient says, "I feel a lot better since I ran out of the pills you gave me." And to be honest, sometimes the best thing the patients can do is to stop the medication. Obviously, not by themselves. They should check with the doctors first. This was a study that we did in Sheffield when I was working particularly with hematology patients. And this was a study of multiple myeloma patients. It was a study of patients, and not about their myeloma treatment, but about their pain treatment. And we asked, it was a medical student who was doing the study, asking patients about what side effects they felt they were getting from their pain medication. And you can see there's a long list of side effects. Most of them were moderate or severe. But the important thing is we asked them about what impact those side effects were having on their quality of life. And we used the EORTC quality of life scale, a validated scale. And we found that patients who did not have any significant side effects related to their analgesics had a pretty good quality of life, 62 out of 100. But the patients who did have analgesic side effects had a much worse quality of life, less than 50, 48. So that was a really important message, that even the drugs we're using to help patients with their pain, with a condition like multiple myeloma, are impacting on the quality of life. So the take-home messages I gave in my previous talk, and for this also, is that it's really important for all professionals who are involved in cancer pain management, doctors, nurses, physiotherapists, all, we must be aware of other symptoms. And we must be aware that symptoms are actually side effects of the drugs that we're using. And for that reason, we should always be thinking about non-drug treatments, including interventional pain treatments, but also non-pharmacological treatments such as acupuncture, exercise. Hope we can talk about those. We need a holistic approach in assessing the patient and in managing the patient. And it's really important for the pain specialist to be there helping to coordinate the treatment of the patient alongside the oncologist, alongside palliative medicine. They have a very important role. Thank you. I'll stop sharing. So,
thanks, Sam. I think we have a question here. The first one is, at end of life, especially in last days or hours, OIH with SC opioid, what is your advice for management?
So this is talking about in the last days of life, opioid-induced hyperalgesia, how to manage that. The most important thing is recognizing it, because at the end of life, it's quite common for pain to increase because the patient's disease is progressing, but they may be going into renal failure, which means that there may be, particularly with morphine, we know that there is retention, a failure of excretion of toxic metabolites, and then actually the pain is increasing not because of the cancer, but because of even, say, opioid metabolites. There are lots of other reasons for opioid-induced hyperalgesia. We can't go into those. So the first thing is to recognize it. The second thing is to weigh up how near the patient is at the end of life. If it's a matter of hours and days, Maybe sometimes we have to accept that and add in other approaches alongside opioids, if possible, to use. Don't keep increasing the opioid. That's not going to help. Hold the opioid dose, but add in non-opioid medication, add in massage, other treatments which can help to calm the patient down, because often those same toxic metabolites could be causing delirium. So pay attention to those symptoms as well. If the patient has a longer prognosis of many days, sometimes longer, then you can think about even tapering the opioid dose back, but being careful that you don't provoke new pain, and maybe substituting an analgesic which is less likely to cause hyperalgesia. Buprenorphine, for instance, is anti-hyperalgesic, but you need time with buprenorphine. You need at least a week or so to adjust the patient. So it depends on how near the patient is at the end of life.
Sam, can I ask you about this? What's your view on other adjuvants, like in the same sort of situation, end of life, or maybe not very near, and maybe there are a few weeks or sort of, few weeks left, about other like ketamine or clonidine or other sort of, or steroids or maybe benzodiazepines, like what's your view on these kind of treatments where you have sort of diagnosed that, yes, this is the case of opioid-induced hyperalgesia and these opioids are making it worse?
Excellent question, Manohar. And that in my view, I think for a long time we were kind of misled by the need for having a simple approach for pain management. Maybe that was okay in the 1980s and 1990s, but we're much more sophisticated now. We have many more drugs and we understand how to use those drugs better. And therefore, we should not hold back from using what is commonly called adjuvants. Now, I don't like the term adjuvant because it suggests that all those other drugs are somehow inferior to opioids. Actually, sometimes the best thing to use is those other drugs, and I would often start using drugs like pregabalin and duloxetine as other ways of attacking pain, and not necessarily using opioids. The situation you're talking about, where there is opioid-induced hyperalgesia, if you've got time and if you've got expertise, I find ketamine is a very, very good approach. You can go in with intravenous ketamine. Maybe if you haven't got facilities, you could use subcutaneous, but it's not so fast. With ketamine, you can actually reset pain levels. You can reduce the pain within minutes, within almost seconds with intravenous. You can see the benefit, and then you can reduce opioids. Depends on how long the prognosis is. Again, you can continue the ketamine as an infusion. If it's only going to be a couple of days, that could be very helpful. But sometimes if the patient has a longer time, the ketamine, I would say, should be maximum 5 days as a kind of blanket to reduce the pain level, and then reset with the lower doses of other drugs. But always think about adding pregabalin, duloxetine. Benzodiazepines, I would suggest mainly if the patient is agitated, unable to sleep, not necessarily as an analgesic by itself, because they will always cause, reducing of consciousness level. We must remember patients at the end of life don't always want to be unconscious. They want to be taking part in life with their families. They want to communicate. They want to be able to eat and drink. So we must do everything to prevent them from becoming have reduced consciousness level.
Thank you. And also, I'd just like to add, Sam, you gave a really very comprehensive, a great answer. And I'll just like to add that I think in hospice setting, inpatient hospice setting toward the end of life, occasionally we also see some cases, not all the time, but occasionally we have some pain syndromes, pain issues, where sort of we may have some interventions to offer within a hospice setting. For example, we could do a saddle phenol block, or we could do sometime running epidural infusion or intrathecal block, or peripheral nerve block, just running an infusion, just to kind of, if you have a localized pain syndrome, which could be tackled maybe in an alternative way, then that could also help you sort of reset the pain and maybe reduce your opioids and tackle the hyperalgesia. And then by the time your other intervention wears off, you probably are not in a situation of opioid-induced hyperalgesia. And you use the word reset, like with ketamine, you're saying that you're resetting the pain, so it's for 5 days and all that. I think that's exactly the point. I think we are also seeing now in chronic pain setting, where some people with chronic pain have a fall, pain gets much worse, and then other treatment for pain that stop working. So where I think ketamine is being used now more and more in same sort of philosophy to reset that sort of pain aggravation, that exacerbation, and I think we find it quite helpful.
Yeah.
Thank you.
But Manohar, you make a really good point about the fact that physicians like me who are working with drugs all the time, we must remember that there is a limit to what you can do by just putting drugs into patients' mouths or through into the veins. Sometimes we need to use interventional techniques, reaching targets in the spinal cord. When I started working in hospice 30 years ago, we had an anesthetist who would come once a week to the hospice and asking, we had a clinic, and we said, are there patients that you're struggling with? He could offer to do a caudal block, phenol block in the hospice. Now, I know that there are some hospices which have those facilities. You're very lucky in Liverpool. You have an excellent relationship with your palliative medicine colleagues. I'm concerned that there are some places where they don't have that good relationship with the local pain clinic, where interventional treatments cannot be offered because patients are then being denied the chance of having a block, or as you say, sometimes an anesthetist can come in with short-term clonidine. I'm not experienced with clonidine. I'm very experienced with ketamine, but there are other things that an anesthetist who works in pain management can bring into even a hospice setting and actually really give good quality of life for a patient.
Thank you. So other thing I wanted to check with you, that EFIC has presented a sort of their guidelines on opioids and non-cancer pain. And it is pretty sort of negative in a way. It's not very inspiring to use opioids for non-cancer pain. But what's your view about cancer pain itself? Or maybe cancer pain at different stages, like, some long-term survivors, or maybe those terminally ill. What's your view on that for opioids for cancer pain in that kind of scenario?
Yeah, Manohar, I'm old enough to remember when the WHO published its WHO ladder in 1986. I was there. I was actually a consultant in palliative medicine. We knew already at that time that opioids are important. But what the WHO did, the World Health Organization, is it kind of enshrined it. It wrote it in tablets of stone that opioids have to be there, the central part of opioid management. And of course, that was an important message in the 1980s and 90s. But as I said before, as we got more drugs, more familiar with other methods, and also as cancer patients live longer, we realize there are limitations to opioids. And I agree with you that we can be sometimes a bit negative about opioids, that there's very good evidence, for instance, in chronic pain, that opioids probably end up doing more harm than good. They're great for acute pain, surgical pain, trauma pain, but not for chronic. We must realize that also in, for instance, cancer management, in survivors, people who've come through treatment, but they still have pain, maybe because they had post-surgical pain lasting now for many months or years, or they get complications, late complications of cancer treatment, neuropathies. Maybe it's not the best thing to give them long-term opioids, because that group of patients are trying to lead a more normal life, maybe go back to work. So there are limitations on opioids, but we must not be afraid of using opioids when there is a good indication. And I think that there's a kind of backlash that we've had from the opioid epidemic, which has tended to restrict the use of opioids, sometimes too much, even for cancer patients. So it's a very difficult balance, Manohar. And again, I think the important message is physicians should not be making these decisions alone. They should do that as part of a team. They should have input from nurses who see a different side of the patient. They should have input from other allied health professionals who can offer things to make the patient's life more comfortable without relying on drugs, but using other aids as well. And particularly, physicians should call in anesthetists to see if there's something interventional that can be done. That's your role. And that's really, and I want to hear more about what you can offer.
Thank you. So I got one question from Felicia Cox. So I'm pleased that she is also on the line. So it's nice. So question is for you, Sam. What she's asking is it then the time to review place of opioids on WHO ladder and perhaps to adapt it to include intervention as step 4? I mean, I'll modify this question also myself, that maybe to include interventions at not only step 4, but all along the ladder from step 1 to 4. So what's your view on that?
Okay, if I may share my point of view, I stopped using the WHO ladder many years ago in the year 2000 because I thought a stepwise approach is very simplistic, and it's great for people teaching students how to approach pain, and it may be very important for places where they don't have access to the same interventions, the same range of drugs. So it's okay, but for, let's say, for more sophisticated societies where we have access to all these things, I would not use a stepwise approach. I would go in sometimes multimodal from day one, and I would offer, pregabalin or gabapentin. I would offer duloxetine at the same time as the opioid. So it's not that they came later. The opioid is part of a range of things we can do, but also always remember non-pharmacological as well. So I'm not suggesting to Flick or others that opioids have no place. Of course they have a place. All I'm saying is we mustn't worship opioids as if they were something magical. They're just part of our range of treatments. For individual patients, opioids can be the main thing, or it can be a minor thing for another patient. And that comes back to the importance of always assessing our patients very closely. Phenotype the patient, see what the causes of pain are, and adjust the management for that patient.
Sam, I'd like to ask you a question now based on what you've just said on our assessment. So you've both made it clear that we should be trying to optimize the patient's quality of life, maybe use non-pharmacological treatments, other ways. This sounds like it needs a team. And in your talk, you spoke about the ESMO clinical practice guidelines, and you had a column on the right about care. Would you be able to describe a bit more about that for the listeners? Because that seems very non-medical, but maybe something that we wouldn't expect near the end of life, where there might be a focus on drugs.
Well, I don't know the professional background of all the people taking part in this meeting, but I think it's really important to share that, having worked in the cancer area for 35 years, we accepted very early on that cancer management, the whole of cancer management, is multidisciplinary. We cannot make decisions without having a multidisciplinary view. Sometimes, of course, an individual has to make a rapid decision, but usually decisions come back to a team, and the minimal team is a doctor, a nurse, a physiotherapist, a pharmacist, and then we bring in psychologists, etc. And when we're talking about that big, broader approach, and we're talking about care, it's saying drugs are important, doctors' contributions are important, but all the other things are important as well, and sometimes more important in the patient's life. Remember also, the patient is usually there with the family. The family need a lot of care, because if the family need to be educated, education is an important part of this whole approach. Patients need to know why they're taking these drugs or these other interventions. The family needs to do that so that they can support the patient. So often we see a great plan made for a patient. The patient is told in the clinic, here, do this. They go home, nobody else understands it, and it all falls through, because the family are not supporting the patient. So it has to be multidisciplinary with as many members of the team. I would also include dietitian in many of my patients' care, because if they're not getting the right nutrition and they're cachectic, they're weak, they can't mobilize, it's a very complicated situation. So I think we need to be thinking on a broad level. It's challenging, but it's also very rewarding, because patients thank you, because their life in general it improves.
So we have a related question to that from Martin Galligan. Hi, Martin. So who do you think is best placed to coordinate the care of patients with cancer-related pain? I agree that it should be a multi-professional, multidisciplinary approach, but it can be a challenge to bring all these teams together, especially in those with persistent cancer-related pain after treatment is finished.
Thanks, Martin, for that question. Again, speaking from a position of working in a British system where we accept in the cancer setting, there's always a multidisciplinary team of sorts. Nearly all of our patients will have a specialist nurse following them through their treatment. Maybe the nurse will change after surgery to a chemotherapy nurse or to a palliative care nurse. For me, I think nursing is absolutely key. And I have to say, sometimes I play a secondary role. Not sometimes, very often, I will play a secondary role to the contribution of the nurse in assessing the patient, in explaining and educating the patient, and in monitoring the treatment. Many of our nurses in the UK are also prescribers, and I would respect nurse prescribers because they are absolutely sometimes a little bit more up to date in things than some of our older doctors say. So doctors are important, nurses are important, but in an individual case, a patient may relate mostly to another member of the team, and that whether it's a psychologist or others. And sometimes a lot of the management can be routed through that other member if the patient has most confidence in somebody else and who can maybe also make contact with them at home as well. Patients feel abandoned once they leave the hospital. So it's great to have them to have a telephone number where they can contact somebody. It's not always a doctor then, it's somebody else in the team, a nurse or a psychologist, for instance.
So if I may add, Sam, just to give a flavor of, I agree with exactly what you said, but there are different parts of the world, different countries, different places. There may be some local sort of interest, local leadership. So I think in Liverpool, our palliative medicine colleagues are the main driver for the whole sort of service. They kind of, keep us in the loop, and they kind of keep informed. They are, I think, first point of contact for the patient, like in any issue they have, admission, aftercare, with the procedures. So they kind of drive it, and they kind of coordinate with the oncology side and with the pain medicine. And if somebody needs a spinal intervention, like from a neurosurgeon, so they kind of closely working with me, they will be linking with them. I think it all depends in each region who has the most time and interest and enthusiasm. So it could be anyone who is really dedicated to this, but this will be a different person in different part, even in the UK. So I think I can see your model, how it worked, because, but in Liverpool, I think we traditionally have palliative medicine working very closely with pain medicine driving it, but palliative medicine usually takes the lead. And we probably are doing other stuff in the pain clinics and all that. So I think that's what works for us. But I see that the patient usually are able to have more relaxed conversation with nurses because they spend a lot more time with them. So I think it may be a sort of reasonable plan in a region where somebody is senior who understands what patient needs, and patient understand what's being offered, and empower patients or these people to sort of see their options and help them to reach a decision how they progress and what are their pros and cons or backup options. So I think, but somebody has to drive it. Somebody has to be, I think somebody has to be really recognized that this is the person responsible, because when we receive a referral to our service, they come from different disciplines. That to me tells me that somebody else is leading in that region in taking a call to drive it further. So I think that it's important that somebody is there. It could be anyone, I think, as you said.
Manohar, you're so right. And I think it's really good that you mentioned other disciplines within medicine, that it's not just palliative medicine, pain medicine, but actually, remember, there's usually an oncologist there. This is cancer we're talking about. And I think we sometimes forget the important role the oncologist has. And I think when we talk about education, we have to always remember we need to be constantly educating our oncology colleagues. They are absolutely up to date in cancer management. They might be a little bit out of date in pain management. And sometimes all the work we do with the patient and the family and the other members of the team falls through because they see the oncologist in the next clinic and he says, well, why are you on this drug? You don't need that. So you have to keep your oncologist up to date. And I would make, for instance, my team would be involved in the weekly education program for oncologists, hematologists, so that we will come in, give a little brief update about pain management every 6 months, certainly when the doctors change, the new training doctors change, so that they know this is how we manage pain in this particular clinic, this department. So I think it's important that we respect the role of the oncologist, but also make sure that our job is to keep reminding the oncologist that maybe they might want to change the pain management, work alongside them. Nurses, of course, work both in oncology and in pain and palliative medicine as well.
Thank you.
Sam, I have a question about one of the non-pain symptoms you spoke about in your presentation. You spoke about fatigue being one of the major complaints, like more so than pain for people at end of life. How would you go about treating fatigue, assessing fatigue and treating it? What are the main, would it be more medical approach, non-pharmacological? What do you think?
Right. I think the first thing is to recognize the absolute importance of fatigue. We're talking about pain here. This is a pain organization, but we must remember that survey after survey of cancer patients show that in fact the commonest symptom is fatigue. It's higher than pain, and often it's the one that has more impact on daily living. So, we're used in pain management to assess not just the pain severity, but also the impact that pain is having. We use tools like the Brief Pain Inventory, which ask about how pain is impacting on sleep or activities or work, etc. Similarly, fatigue has an impact on all of those different aspects of life, and often very much more. You don't have to use a questionnaire. You can just ask the patient, when you're tired, what is it that you can't do? What stops you, enjoying life? So it's important, first of all, to recognize that fatigue is important. Don't just say, well, oh, you've got cancer. That's what you expect. No, you should not expect fatigue. There may be things cancer may be causing because of whether anemia or hyponatremia, lots of metabolic reasons, hypocalcemia. Of course, eliminate those. A good doctor should think about all those things, eliminate the medical causes of fatigue. And then, of course, as we said before, look to, could it be a drug cause? Could it be one of the drugs we're using? Now, technically, opioids don't cause fatigue, they cause somnolence, but actually from the patient's point of view, it's pretty much the same. There's cognitive fatigue, they can't think straight, and they are just sleepy. But there are other drugs, which will actually reduce, will have an impact on muscle function. So your benzodiazepines, their muscles will be weaker because these are muscle relaxants. They can't be so active. So always review all the drugs and things which could be causing fatigue. In terms of managing it, I think you have to think about getting back to the patient. What is it you want to do? What is the thing that you really want to do? Well, in some patients is, I just need to be able to get up, walk around the house, go into the garden for a few hours. That's all I need. That's a manageable thing because you can, particularly with a physiotherapist, occupational therapists have a big role in looking at how you can adapt the patient's life. Sometimes the most important thing is giving patients a walking aid. No, they never thought of that before, but with a walking aid, they can actually get out into the garden and sit there for a couple of hours. Some patients may want to go shopping. Now that needs a little bit more attention. And for instance, they might need ways of managing pain, which are not so sedative during the daytime. You may need to sometimes be flexible with the pain management to use more sedative medicines at nighttime, but actually avoiding sedating measures. So do not use benzodiazepines during the day, because patients will fall asleep in the car on the way to the shops and they can't get out. So let's be smart about how we use drugs and how we actually gear the fatigue management for the patient. Of course, that you can recourse to drugs. So I was very skilled in using methylphenidate, for instance. So some patients could have a dose of methylphenidate at a particular time of day. They'll wake up, they'll be more active, do the shopping, go to the clinic maybe, but then they don't use it regularly. So drugs like psychostimulants have a role. I found methylphenidate much more useful than, say, modafinil. But the point is, get familiar with the approach and use it carefully, use it sparingly, not all the time, but it can make a big difference to some patients. But coming back to the thing about nutrition, make sure that the fatigue is not because the patient is undernourished and cachectic. Now, Cachexia is a difficult thing to manage. That's a whole different story. But let's make sure the patient has a good intake of carbohydrate, protein, nitrogen, so that they're actually maintaining, if not building, muscle mass. You can't always build muscle mass, but try to maintain muscle mass. And for instance, I would use omega-3 fatty acids, EPA, because there's good research evidence that if you add that to the diet, you can help to maintain muscle mass in cancer patients. So let's be sophisticated and not just say to the patient, well, you're fatigued, well, that's what you expect with cancer. No, don't accept that.
And you said the importance of maintaining muscle mass, and also you mentioned a walking aid in terms of physical activity. What about structured exercise programs? Like, I'm a physio by background, so that's my bias towards exercise. But
Mary, you can tell us a lot more about that. But what I can say is there are increasing evidence of exercise programs. In a sense, we kind of borrowed those from cardiopulmonary rehabilitation. We took that model, pulmonary rehabilitation, cardiac rehabilitation, and we brought that into cancer. Let's not be proud. Yeah, we learned from those other specialties, but tailoring exercise, structured exercise programs, graded exercise programs, nothing is worse than telling a patient to go out and walk 20 minutes every day when they are so tired, they're in so much pain, and they give up. No, grade it, have daily, weekly targets they can reach, because we know that exercise is in fact anti-inflammatory. It actually helps to reduce, mild, doesn't reduce cancer pain, but it reduces some of the more musculoskeletal pains. But actually don't make your patients overreach at the beginning. Give them a graded, and to be honest, physiotherapists are the best people to advise on that.
And I guess what I'm thinking is, for the patient, what is their perception of this more holistic view? So when you bring in a dietitian, a physio, a psychologist, is this something they're accepting of, or can they be confused by it if they just, depending on their belief about cancer and whether they should be exercising and whether they should be engaging more? Is that something that can be tough, or is it something that people can understand from the get-go?
That's a really good question, Mary. And I think, reflecting back on my practice, I think that because we would introduce these other members of the team early on, they kind of accepted them as being, oh, here's a physiotherapist, come and have a word. Or you mentioned something about food. Okay, we'll just, arrange for you to meet the dietitian next time. So bring them in so they see they're part of a team. I understand what you're saying. Sometimes they think, well, I'm a cancer patient. I just want to see my oncologist. Why am I seeing you? You're palliative medicine. You need to say that actually we're part of a team. And once they see what each individual member can do, they might actually say, well, thanks very much. I don't need all the others, but I just want to keep talking to the dietitian because I like what they're telling me. So I think that it's important. We mustn't assume that the patient knows what all these different specialists are. They've never seen them. And many patients will say, well, I've seen my oncologist, I've seen my GP, why do I need anything else? Maybe if they're lucky, they don't, but actually, for most cancer patients, they benefit from those others. And it's like you do, Manohar, in Liverpool. They get introduced to palliative medicine early, and with palliative medicine comes a whole range of other nursing and other disciplines. And so it's brought in at an early stage. Nothing worse than waiting till a patient is really sick and then saying, we're having this person, that's scary for the patient.
I think the interaction the patient and the family have with the medic who's leading their care, I think their words are very powerful. And if they introduce as an oncologist, for example, you said, look, now we have evidence coming now that a person having more physical activity and a sort of a whole stronger musculoskeletal system probably are able to handle the pain somewhat better. It may not reduce it, but may fight it better, or having a better diet and better nutrition may help their body to handle the pain, using some terms in a way those people understand. Then I think when they come to dietitian and to physio and other discipline, they probably will be geared and they'll understand. Otherwise, half the time when they're with other discipline, they won't even know why they are there and what's the relevance. And I think so we should use our time with them in a very careful way, because our words are very powerful. And sometimes we don't use them, then the patient, I think we are probably the reason sometimes the patients get confused. They don't understand why they are seeing other disciplines, like all those psychology support, physio support, spiritual support, social sides, social sides, and all, as you said, they may sometimes just need maybe a stick, support, or maybe we have patients, sometimes they have an issue with their finances, their mobile phone connection is cut off or something, and they just need to talk to someone just because they are distressed. So I think we have had those issues, and you help them get the support for them, and suddenly they look more relaxed and they are less distressed, and within a sort of total pain concept, some of the patients can be handled in a different way rather than tablets or injections.
Yeah, I mean, I started my career as an oncologist, but I left it quite early and moved into palliative medicine. So I've got great respect for oncologists. But I know that sometimes, if I can say this to this one, sometimes oncologists are the problem, because they are out of date. They don't understand pain. And for instance, if a patient says, well, I want to go, shopping, but I get a lot of pain. Well, the oncologist will say, well, maybe you need to learn, let that go, let your wife do the shopping or your husband do the shopping. I would say, no, you want to go to shopping, you've got pain, then whatever else your background medicine, take this fast-acting drug. It could be a short-acting oxycodone, it could be a fast-acting fentanyl. For a couple of hours, you'll have pain control, and then you'll go back to your base. So, that's a more sophisticated approach than just saying, oh, don't do that, because you should scale down your expectations. No, patients have expectations. We should respect those. And if possible, we should allow them to meet those expectations.
Sam, do you still think that's common? So let's say today's oncologists, can they still have within a team, like we're talking about multidisciplinary team, do you think people are still not singing from the same hymn sheet? Because obviously that makes it difficult for the other professionals. Yeah. Do you still think oncologists maybe set lower expectations that might confuse the patient, and then that makes it difficult for the other health professionals, or has it changed?
Right. It depends if I'm going to be quoting. No, I think it's fair to say that you would expect that oncologists, being very expert in oncology, can't be expert in everything else. And a good oncologist will recognize that, and they might bring in, for instance, a diabetologist, they might bring in a cardiologist for certain problems. They need to recognize the role of pain and palliative care as well. And in the kind of centers that you work in, Manohar, I've worked in many centers, oncologists are absolutely part of the team, and they recognize what they can do, what they can't do, and they recognize what others. But I have to say, in some places where they're, maybe because the palliative care is not so well developed, maybe because the pain management services are at the other end of the town from the oncology, so they hardly get access. They tend to work within what they know they can offer the patient, and they tend to forget, oh, there's a role here for a pain management, there's a role here for palliative care. So my approach would be keep bringing your expertise back. So from day one, when I started working 30 years ago, I went to the ward rounds with the oncologists, and they were thinking, well, what's he doing here? And then I would chip in, and I can say, well, I can see that symptom that patient had. Can I suggest something? And as you go around some good results, they'll say, well, come along and see this other patient. It's no good trying to sit in an office at the other end of the town and giving lectures until you actually go there. You know this, Manohar, you need to see the pain medicine and the palliative medicine on the ward, in the clinic, alongside the oncologist.
Yeah, so it really highlights the importance of communication between the professionals. A question I had for both of you is regarding non-pain symptoms. Are patients generally good at coming forward saying that they are having these symptoms and actually asking their professionals what is causing these? Or can people be generally silent about these symptoms, expect them to be part of their care, and it falls more on the professional to be asking? Or where does the balance fall, do you think?
You go first, Manohar.
I think patients generally feel when they come for consultations or they have interaction with the clinicians or healthcare professionals, they generally tend to come out with their most pressing symptom. And others, they are always concerned to distract clinicians. So they always come out to us with the most pressing problem. And there is a whole load of other issues they don't even talk about. And I think more time we spend with them, more we assess them, more comprehensive we are, more our other healthcare professionals engage with the patient, then suddenly you begin to unravel that what all is going on. But I think patients generally are quite sort of, and they're not all very good historians as well. Some are very good, but I think some people don't even know what to tell. So I think we have to even ask the most pressing symptom. We have to ask even more details, to so that we make understand what that is. So I think there is definitely an issue there that how patients come across with their symptoms to us. Yeah.
Yeah, Mary, that's a really good question. And I just want to add to what Manohar said. I think that the whole thing comes back to assessment and how we assess a patient holistically. And there is a tool. We use a holistic needs assessment tool, and it could be a questionnaire, it could be a checklist. We developed one in Sheffield, a questionnaire. And that shows, as you say, Manohar, that the patient doesn't know where to start. They come along, I've got pain, but there's actually lots of other symptoms they don't talk about. And unless we, tease that out of the patient, either with a good interview, if you've got time, or with a checklist, for instance, we would give the patient the questionnaire in the clinic while they're waiting in the waiting room, and they would fill in the questionnaire, bring it in. When the patient sits down, you have that discussion, and then you say, well, let's look at your questionnaire. Oh, we haven't talked about your sleep problem. We haven't talked about your constipation. Oh yeah, please, can we talk about that as well? So a holistic needs assessment tool can be really helpful for initiating those discussions. And I think the other important thing to say is that, patients will, as you say, patients will be either, well, you're the doctor, you decide, or increasingly patients say, well, why? Because, they'll say, well, my GP said, I should just take this medicine. Why am I having to take another medicine? Or why should I reduce my opioid? If you sit down and explain, they're so grateful. Depending, of course, on the patient's intellectual ability, educational, you have to explain it in different language. And as professionals, healthcare professionals, we must be good at explaining at different levels, not talking down, not trying to, showing not to confuse them. But I think what's important is patients appreciate having these things explained to them. It comes back to Manohar's, normally in palliative care and in pain, we have longer times with our patients, don't we? Not like a 5 minutes with a GP, but I would just give 30 minutes minimum to some patients, maybe longer. And for instance, one of the tools I would do with patients, say got neuropathic pain, say radiating pain, I would have on my iPad nerve charts, and I'd explain, I'll show where that nerve is. And they'll say, well, yeah, now I understand. The disease is in my back and I've got pain in the back of my heel. Nobody explained that before. So they appreciate understanding why they've got that pain or another symptom as well.
Now that you mentioned about nerve pain, Flick had a question. Hi, Flick, Felicia Cox. Is it common for supportive and palliative care to use neuropathic pain screening tools? So Sam, you said you can show them a diagram, but do people use actual screening tools, do you think? Or
screening tools for neuropathy, right? In oncology, I have to say probably not common. I think it tends to happen in specialist centers where people are working in this kind of complete multidisciplinary team. I think oncologists are very good at recognizing neuropathic pain because, after all, they cause it. They cause a lot of neuropathic pain from their drugs, initially by surgery, but chemotherapy drugs, targeted treatments, bortezomib, for instance. And then we also know late effects of radiation, sometimes years later, causing nerve damage from fibrosis. So oncologists have woken up to this, but they don't know, they can recognize it, but they don't know how to assess it necessarily. They don't know how to separate it from nociceptive pain and therefore use different drugs. That's where we step in. We're sitting alongside them, we're looking over their shoulders. Well, maybe, I see that you saw the patient in clinic last week. You realize the patient's got neuropathic pain, but you just increase the opioid. Maybe that wasn't the best thing. Can I suggest you do this? So it's assessment, I think, Flick, is not as good and as thorough as it should be, but that's because it's occurring in the busy world of oncology. You have to recognize oncologists have got a major job to do to treat cancer. But as the cancer progresses, after treatment, then, we've got a bigger role as well.
Manohar, do you have any views on the neuropathic pain screening tools?
I think in our setup where we have joint assessments within pain and palliative medicine for cancer-related pain cases, we don't use those screening questionnaires until and unless that is part of a research. So within that, we will be using neuropathic screening pain questionnaire, or if they're going for an intrathecal pump for cancer-related pain, in those cases, they will be undergoing that neuropathic pain screening tool questionnaires. But typically for a standard assessment, we are seeing a new patient, we generally don't, because we think probably we can make a judgment of the pain features, neuropathic or not. And often we consider that, yes, often there is a balance of pain, although we divide between neuropathic and nociceptive and myofascial and all chronic primary pain and all that. I think there's always a sort of yes, one may be more predominant in a particular patient, but often we see in our palliative care patient that we generally have a mixture of pains and sometimes one is more predominant, but generally they have mixture of all different pains together, so yeah.
Manohar, can I ask you, I'm sorry.
No,
can
go
I ask
ahead,
you a
Sam.
question? At what stage do you think it's appropriate to go with intrathecal drug management? I'm thinking of patients who've had escalating doses of opioids, getting to the level where they're now very sleepy, to getting a lot of toxicity. And we're talking patients about with advanced cancer. What do you think the role is of intrathecal drug management, and particularly how you follow that up?
I think intrathecal pumps for cancer-related pain are commissioned for routine commissioning in England. So NHS England will fund and commission and support it. And it's a shame that NHS England will fund it, but not a lot of these are happening. And the issue is that we have a lot of patients who can benefit from those. We see a lot of patients who have typically pain below, diaphragm, pain not responding to sort of your typical opioids and other medications, and pain is escalating, the medication escalating, and pain very distressing, and they have more than 3 months to live, 3 to 6 months to live. These will be the patients who have unresolved cancer issue are suitable for intrathecal pumps, but there aren't enough services sort of spread out in England, where once the patient is implanted with a cancer pain pump, that they can have a refill close to there's no issue aftercare, because intrathecal pump requires aftercare. Every few weeks or 4 weeks or 6 weeks, the pump reservoir needs to be replenished. And that is the issue we're having, that if they live in Liverpool, we are pretty okay to do that. But if they come from Manchester or beyond, then patient can't have access. It's really very unfortunate. So I think we have a really a sort of lot of people who can access this treatment, who should have this, but at the moment they're not having it. And this is just the way the services are spread out and are developed. And I think it's quite a sort of shame for. And also, we have some patient who had intrathecal pump implanted, and if they're from a distance, toward the end of life, they can't have a refill at home, for example, and that's really very distressing for the family and for the patient to convert to a syringe driver. And it's really a very poor experience for those cases, and it's really, they will remember for the rest of their life, the families, what happened, because it's so distressing. So I think we really are in really desperate need to set up those services, because this treatment has got a good evidence, and it's commissioned and funded, but it doesn't happen.
Yeah. In Sheffield, part of the training for our palliative medicine training doctors was to learn how to go out with the nurses and change the pumps, and sort of, so that they were playing an active role. Can I just, I know we're running out of time, can I just ask you, Manohar, across Europe, what is the availability of intrathecal pain management?
Oh, I think it's even. I think in Europe, I think it's even less. I think in England, I think we are doing some pumps. I think doing small number. We're probably doing only maybe 20%, 30% of what we would otherwise be doing in UK or in England. I think in Europe, I think it's even dire. You know, I think even more distressing that they don't have access even to running epidural infusions by external sort of pump. So I think. And also it's a cost issue, the service, the expertise and the services and the commissioning, how they're funded. I think that's really an issue. And if you go to them outside Europe, I think it's it's very bad, that people don't have access to that. Yeah.
I think we have time for one more question. We have a question from Moja Marhum. Hi Moja, I hope I've said your name correctly. So role of nerve block by anesthesiologists in managing chronic cancer pain, for example, pancreatic cancer, would you recommend? Is it recommended?
Yeah, I think for chronic like pancreatic cancer pain, there are some randomized controlled trials and there are also some systematic reviews. And also it's part of ESMO sort of guidelines that celiac plexus block or splanchnic nerve block either with a radio frequency technique or with the neurolytic block in the splanchnic nerve is one of the established and recognized treatment, which is known to reduce the pain level and also reduce the opioid intake and also improve appetite and general well-being. So there are some randomized controlled trials on that. And but again, sort of nowadays there's a move more toward when these people are having surgery, they go to hepatobiliary surgeons. They probably will do that, that splanchnic block, or they will do the under direct vision. They will cut those nerves in some leading centers. But otherwise, this is established that there is a good evidence to support this for pancreatic cancer. Yeah.
Okay, so time is almost up. I'd just like to bring this to a close. That was an excellent discussion, Manohar and Sam. Thanks very much. I think we covered a lot there and it was very free-flowing. So thank you everybody for attending. I hope you enjoyed the question and answer session and see you at the next webinar. Thank you, everybody.
Thank you. Thank you.
Thanks so much.
Thank you.